So I'm very pleased to introduce our first speaker, Dr. Paul Moayyedi. He's the director of the Division of Gastroenterology at McMaster University, or former director of gastroenterology, holds the Audrey Campbell Chair of Ulcerative Colitis Research, and is the past president of the Canadian Association of Gastroenterology. He's obviously very well published and very famous, and he's going to be talking about the primary prevention of gastric cancer through treatment of H. pylori.
Thanks very much. And thanks so much for the organisers for inviting me to this conference. It's a real honour for me to be here amongst many people that have shaped my career or I've worked with, like Ernst, earlier on in my career. And also I'd particularly like to highlight Julie Parsonet, who has already spoken, as hearing her present her work on gastric cancer and H. pylori encouraged me to go into this field. So I don't have conflicts of interest, and what I am going to present is the update of the Cochrane Review, looking at primary prevention in populations to prevent gastric cancer. This is work done for the IARC conference led by Jin Young Park, and she's already spoken earlier today. And so this is to inform that IARC meeting on the current status of prevention. And what I would say is, a lot of this conference is around intestinal metaplasia, and you see cool pictures and wonderful endoscopic skills. But any epidemiologist would tell you that preventing the disease in the first place is far better than trying to detect it early and cure it. There is no doubt. And so, Michael, not that I'm blaming US immigration because we didn't know about H. pylori then, but if they tested your parents and you when you came to this country, you may well have never needed surgery and the anxiety that came with it and have a full stomach today. So I think primary prevention is really important, and I will show you the evidence we have today that it works. So overall, we now have 11 randomized trials, which is the gold standard of evidence, looking at 58,000 participants. What I would highlight with that 58,000 is that it includes the LINQ study, and I'm grateful for Wei Qing for providing me the ICC for that study because it was cluster randomized. So there's far more people that have been looked at, but you have to lower the sample size to account for clustering, which is why you see these odd numbers, just to emphasize that. So anyway, we've got 8 trials in healthy individuals in general populations. And we have a healthy number of gastric cancers, sadly, in this group. And what's pretty clear is that you reduce the number of gastric cancers if in those randomized to H. pylori eradication. With a number needed to treat in predominantly, well, almost exclusively East Asian populations of 228. That is a very low number for any screening program, admittedly in high-risk regions. They also looked at early mucosal resection in early gastric cancer. So this was mentioned earlier. So these are people who've already got cancer, removed endoscopically. It's still not too late to treat for H. pylori. You halve the risk of developing cancer in the future with a number needed to treat of 18. So these are the individual trials in the forest plots, and all of them show, or nearly all of them show, a trend to benefit, and those that are high-powered, it is clearly statistically significant. So I would also highlight, it's been mentioned, the Taiwanese study, which we excluded from this, because that was not taking H. pylori positives and randomizing them, which is the most efficient design to see if your intervention is working. They took people with FIT and either gave them an additional H. pylori test or didn't. And as has been talked about earlier, although it's large, only 26% actually got FIT. and only 70% of the H. pylori testing arm were offered therapy. So it becomes underpowered for their primary outcome. But as I say, it's a great study, but it's not efficient design to answer this question, so it wasn't included in this review. But overall, what I would say is that there is moderate quality evidence, which in grade terms is pretty good for a screening program. I would say it's by far the best evidence we have for an intervention that no one's doing in country terms for population screening. And frankly, particularly in high-risk regions, there's no excuse for that. We should be doing it. The only thing is there's a bit of inconsistency between studies, which is why it's not graded high quality of evidence. But there are other studies ongoing. We've already heard from Dr. Choi, who's running the Korean study, which should be publishing in the next few years. And Nick Wald has a UK trial, which may well be publishing next year. There are other trials, but I highlighted the ones where we will have additional data fairly soon. Before I finish, I just want to emphasize there are other benefits to this as well. If you look at population screening and treatment, and here it's in UK populations, I was the first author on one of those, but basically in UK populations randomized to screen and treat and have those that were H. pylori have treatment versus placebo, the number getting dyspepsia over the next 2 years of follow-up was reduced by about 20%. So, and that's reflected in reduced consultations for dyspepsia and a trend towards reduced treatment costs like PPIs. And by the way, both studies are followed up for 7 to 10 years, and that treatment effect persists. So this is going to save healthcare money. Usually screening just costs money, especially if you're endoscoping them. Here you will actually save money because people won't come to see you in the first place. There could be harms. People have suggested maybe it will increase the risk of esophageal cancer or increase GERD. From the randomized trials, there's no evidence for either of these. So for the esophageal cancer, we have 3 trials and 54,000 participants. No signal really for increased esophageal cancer, although I'd emphasize these are in regions that are low risk of getting esophageal adenocarcinoma. And for reflux symptoms, again, no signal that it's harming. In fact, the trend is towards it benefiting, I think, because it's difficult to distinguish in a questionnaire between dyspepsia and reflux. But my conclusions are that if we were to implement screening and treatment in populations, we could reduce gastric cancer by over a third. There is moderate quality that this will work. For low-risk regions such as the general US or much of Western Europe, we would need more data for that. But it does also reduce dyspepsia in the community, and those low-risk regions need to consider this in their health economic assessment of whether this is worth doing or not. I haven't shown any harms in the data we have, but of course, when implemented, you would need to evaluate that further. Thank you for your attention.